Yeah, I'm Dr. Tobias Pottek. I'm living in Berlin and working in the hospital. I'm urban. I'm the head of reconstructive urology. This is a very new and nice position because I can care only for the patients with my specialities. And one of these specialities is the care for the patients with the old word transsexuality. I do a lot of operations for people who need a female aspect of the genital and they are born with a male genital, so-called M2F, male to female surgery. But I also have a lot of patients which are born with a female body and change into a male, and who have problems with a so-called penoid, which has been constructed somewhere else. I care about 25 years now for patients with incontinence and impotence, and used all the products which have been on the market. I tested them, every one of them, and there was one company, an American company, who started with these products. We used their products for several years. There are some details we wanted to have to change over the years, and then there was company from France, later from Switzerland, Zephyr, who did these changes. There was a new artificial urinary sphincter was invented, who is smaller than the old ones. It has only two parts, where you do not need to implant something into the abdominal space. And what's very important, with this system, it is possible to make a post-operatively adjustation. So if the conditions in the patient are changing, that's belonging to life, in the old system you had to change it to make a new surgery. And with this new Zephyr system, it's possible to make a readjustment of the filling, and so to get the patient continent again after a while. And additionally, Zephyr produced implants for patients with impotence. So these so-called inflatable penile prostheses and also rigid prostheses. And the recent thing which was produced as special prostheses for patients with penoids, so transgender patients who have not been born with their own penis, but who got a reconstructive surgery to build up a penoid, and they need to have erections, an implant, and this implant is very innovative, made by Zephyr now. The conventional prostheses we had are made for biological men, which got impotent. And these implants are put inside, they are just taken inside of the corporal bodies of the penis, and they hold them themselves inside of the corporal body. Transsexual men, trans men with a penoid, they don't have corporal bodies. It's not possible to construct them. They have just a penoid of skin from the forearm or the foreleg or of the back of the patient. And there is no possibility to make a fixation inside of this penoid. And so the new idea arose to make a metal base plate here into this prosthesis, which you can fix with screws to the bone, or with special, very stable sutures also. And then you can bend it to the, let's say, to the normal position, or you can bend it to the erect position, and it's fixed here at the bone. This is new, and this is also, there is also a construction for inflatable penile device like this. There you have the normal condition with the reservoir in the abdominal space, a pump in the scrotum, in the neoscrotum, and if you want to have an erection, you have to pump here, the scrotal pump, and then it arises. And if you don't need the erection anymore, you press on this release button, and then the filling goes out here of the prosthesis, and the penis is flexed again. So this is also the nice idea with this base plate to be screwed to the pelvic bone. This is very different depending from patient and from the surgeon also. There are some surgeons who implant the penile prosthesis in the first operation and in the only one operation they do. And other surgeons stage it into different stages. They first make the pinuit, second stage is to connect the urethra, third stage is to implant the penile implant. So there are a lot of things to be thought of before, to be planned before, and sometimes patient doesn't want to go back to his first surgeon and comes to me to make the last step of the implant. Or there are also some surgeons who have no experience with these new implants, and they send the patients then to me because we have more practice in these new implants with the bone screws, especially. Bone screws are normally made by orthopedic surgeons, and in my training, my long training, the first training I had, the first surgical training was an orthopedic training. So I was used to use screws into bones. Other surgeons don't have this experience, and so we are different in Germany. What I do for trans men who do not want to have an erection primarily is the so-called metoidioplasty. One must know that trans men are treated with testosterone, the male hormone, which is produced normally in the testicles, but these men don't have testicles because they have been born with a female body. And if you give these female bodies testosterone, there will arise in half a year, sometimes 1 year, hypertrophy of the clitoris. The clitoris is the counterpart to the male glands, and if you give a clitoris a lot of testosterone, it will grow. So, and this clitoris is able to be changed into a gland of a penis, and then one has to construct from the vaginal skin a new urethra, and from the skin of the outer labia, the penile skin. So these trans men with the metoidioplasty, they sometimes call it so-called clitoris penis, and they are able to pee standing. That's what they want. They want to have a standing position when they are avoiding the bladder. They don't want to have erections. That is it's another condition. The sexual conditions don't have to do anything with the let's say, with a gender feeling. So we have to respect if somebody says, I want to have a small penis to be standing, but I don't need it for my sexual circumstances, and then we can do a metoidioplasty. Here in the time in Hamburg and in Berlin now, I have implanted several of these malleable ZSI implants. I used screws, bone screws, very small screws. One has to drill a hole into the bone as the position for the screw, and then there is a small measurement device where you can see how long the screw has to be, and you just take it from a kit of screws from the orthopedics. The diameter is about 2.8 millimeters, and the length is depending from the depth of the bone. I had one patient where a lot of vessels of the pinuit had been, and this patient, I did not screw the contralaterals, so the right side I did 2 screws, and on the other side were these vessels, and so I used sutures there, which I fixed in the periosteum, in the skin of the bone. I know there are some surgeons who use only the suture technique. What will be better, we don't know exactly today. The experiences are too short, but we are looking for it. And here in Berlin now, we are creating a big database for our patients to be able to see the results over the years. The problem of trans men is that these pinuits contain different compartments, like this. You need a big compartment for the penile shaft, and you need also a smaller compartment for the urethra to flow the urine. And these both compartments are made from skin. Skin from the forearm, skin from the foreleg, or from the back, or from the belly. That's different depending from the surgeon. And you have to produce connections between the born anatomy and the new anatomy, so-called anastomosis. And these anastomosis, these connection lines, are often the problem in this surgery. Every scar has the tendency to shrink, and if a scar is shrinking, it gets stricture. So these patients have not so seldom urethral strictures, but they don't have a normal urethra. So it's a very special sort of surgery we have to use here. We can use buccal mucosa in some cases. In some cases, we take skin from somewhere else, from the leg or from the back, and make mesh grafts from it, split thickness mesh grafts. And anastomosis can be renewed in some cases. So it's very different, very differentiated, and one has to have a lot of experience and a lot of different techniques to get for every patient the right one. Another thing is that there is some collision potential between the implant and the urethra. One must know also the implant has to bend somewhere. There is to get in the flexed position, and if the urethra is exactly beneath this bending, it might get a compression at this position. And for plastic surgeons, it's sometimes a problem to have the right idea. So these patients are better treated in cooperation with reconstructive urologists, because it's our business from the first day on to care for the urogenital tract, not only for the outer shape of the organs. So for the future, I see a lot of work in patients who had reconstructive urology in their transsexuality life. And the potential is growing. There are more and more patients who are finding us here in our new hospital in Berlin. We treat a lot of patients which are transgender from male body to female body, so they have a female brain or a female gender, but a male body and male genital. This has to be changed into a female one. And one of the most important factors in the female genital is the vagina. So we create a so-called neo-vagina. This is something like a tunnel, which is digged into the body between the rectum, the end of the gastrointestinal tract, and the urethra and the bladder. That's the position of the vagina, between the urogenital tract and the gastrointestinal tract. There is in the male architecture, in the male anatomy, there is nothing but a small layer of fatty tissue, and we open this layer and open it just behind the bladder, so we have a neo-vaginal depth of, let's say, 12 to 18 centimeters length, depending from the patient's size. If one has created this tunnel, this new vagina, one must cover it inside with some tissue, because otherwise it would just heal like every other wound. And most surgeons use penile skin or scrotal skin. We use, in a lot of operations, we use also a part of the urethral mucosa to use it for the neo-vagina. But nevertheless, if one leaves it at the end of the operation untouched, then it will shrink, and after half a year, you won't see it. So there has to be a spacer inserted to keep the tissue wide. And we had long time, we had from the industry a spacer from silicone rubber, which was filled with something like a sponge. You could expand or deflate. And one of these companies closed their doors. They don't produce it anymore. And so we are now, in the moment, we use self-produced devices in the hospitals, taking gloves and fill it with some drapes and so on. But Zephyr now has another idea. We need for the penile implants these silicone balloons like this here, and there is one development. It's a balloon which is a lot longer than this one, and has a smaller diameter. And it will be constructed with a ventile, so it will be possible to fill it more or less with water or air, just following the conditions in the patient. And this is the thing we are waiting for now, because with this, the surgery of the male to female patients will be much easier and safer also.